Welcome, everyone, and good evening. Thank you for joining us in this virtual community lecture focusing on heart health, brought to you by Providence Little Company of Mary Medical Center in Torrance. I'm Jane Neary, the Executive Director of Cardiovascular Services at Providence Little Company of Mary. We are joined by one of our expert cardiologists, Dr. Nazanin Azadi. Before we get started, though, please note that this is a 1-hour session and we will have plenty of time for questions at the end for Dr. Azadi to respond to. Please use the Q&A box to type in any questions you have throughout the presentation, and we will do our best to get to each question at the end. Everyone's audio will remain muted throughout the lecture. Before I introduce Dr. Azadi, I wanted to share something exciting at our hospital. Thanks to Providence Little Company of Mary and USC Keck Medicine's partnership, our skilled physicians and surgeons offer the South Bay community the highest level of expert care and the latest in academic research. From diagnostic procedures to minimally invasive valve and open heart surgery, our patients can seek complex care locally instead of traveling beyond South Bay. Through this partnership, 4 highly skilled cardiovascular surgeons from USC operate at Providence Little Company of Mary Medical Center, Torrance, alongside our exceptionally skilled cardiologists like Dr. Azadi. This partnership continues to elevate cardiovascular care at Providence Little Company of Mary Medical Center. So detecting and understanding our cardiovascular disease risk is important. We are proud to offer affordable and convenient heart screening to our community. We'd like to share this video for more information about our heart screenings.
These are organic power greens. There we go. Jim and I are very active, and we love to cook together.
Jim and Victoria try to lead a healthy life, but with Jim's family history, he and Victoria, too, decided to have an advanced healthy heart screening at Providence Little Company of Mary Medical Center.
Heart attacks run in my family. My mom had a heart attack when she was very young, my age now. My father died from a heart attack eventually, as did my mother. So to be honest, more than anything else, my wife wanted me to go and get checked out. I thought I was pretty healthy anyway, but I went to get checked out anyway.
They were not expecting the results that were found.
I went in there, and the first thing they do is give you, they take your blood pressure, like any doctor's visit, and it was extremely high. It was 210 over 120, around there. They ran the rest of the tests, which were relatively normal, but the blood pressure was obviously a concern.
It's fortunate that Jim had the advanced healthy heart screening when he did. His high blood pressure potentially put him at higher risk for stroke and cardiovascular complications. Thankfully, he's now on medication, checks his blood pressure on a daily basis, and continues his active lifestyle.
What we try to do in our program is to identify early signs or early changes that may help their physicians identify whether they are progressing towards disease.
In addition to a basic heart screening, the program offers an echocardiogram to create images of the heart's valves and chambers, a carotid artery screening to look for stroke-causing plaques, an abdominal aortic screening to detect aneurysms, and a peripheral arterial disease screening to check for blockages in the arteries of the arms and legs.
Your blood pressure is 142 over 84. You take blood pressure medication. Did you take it today? How long ago?
I get calls back many times from participants that they are very thankful for the testing we've done because we've basically set a new course for them, or we've identified some modifications that they can make in their lives, even minimal modifications that can make a big difference over time.
I'm Corey Clausen, and I have 4 fantastic girls, Haley, Layla, Sophia, and Sloan.
Corey and her husband Clint had talked about getting advanced heart screenings because of his family history, but their busy lives got in the way.
In a heartbeat, my world, our world, turned upside down.
While on a family vacation, 44-year-old Clint suddenly died of a heart attack. Corey was shocked to learn that Clint had an enlarged heart with 2 almost completely blocked arteries, problems that could have been found during a life-saving heart screening.
There's not a doubt in my mind if he would have had it done, he would be here today.
Clint's death has left Corey to raise their girls alone and step in and run their restaurant, Four Daughters Kitchen, named after the four girls. Corey is a yoga instructor too, but she makes time to follow her new passion, urging others to have a comprehensive heart screening.
I am such an advocate for these screenings because I believe even a little hint, there's something, you will find out and take you to the next step with it. I would love if we could help anybody not go through what we went through, because it was such a tragedy. So I'm definitely passionate about it, and we'll just keep on going and doing everything I can to keep this going.
Schedule your screening today by calling 888-HEALING or visit providence.org/heart screening. Screenings are conveniently offered in Manhattan Beach, Torrance, and San Pedro. Do it for those you love.
Thank you for taking the time to watch that video. So now it is my pleasure to introduce Dr. Nazanin Azadi. Dr. Azadi grew up in Australia and moved to Maryland, where she completed undergraduate studies in biomedical engineering. She moved to Los Angeles and was named Resident of the Year at USC. She was later appointed Chief Fellow after completing a cardiology fellowship at Harbor UCLA Medical Center and continued on to complete another fellowship in interventional cardiology. Dr. Azadi has published scientific papers, abstracts, participated in educational exhibits, was a leading author at the Society of Cardiac Angiography and Interventions, is board certified in specialized cardiac imaging, such as echocardiography and nuclear medicine. Dr. Azadi is also a physician of the Providence Medical Associates. Dr. Azadi is quite passionate about cardiovascular disease risk awareness and early detection of cardiovascular disease. We will have the pleasure of hearing about these tonight. In her personal life, Dr. Azadi enjoys traveling, playing the piano, and spending time with her husband and son. So without further ado, I'm presenting Dr. Nazanin Azadi.
Thank you so much, Jane. And I'm so happy to be here and to have the opportunity to reach out to the community and talk a little bit about something that's very near and dear to my heart. I love talking about heart disease. I love talking about prevention. And I'm going to go ahead and start with my presentation. So go ahead and share my screen with you all. So the primary focus of this talk is going to be about prevention of heart disease. Those of you who know me know that most of my line of work is in interventional cardiology, and most of the patients that I meet in the hospital, I meet at the time that they've already had their event. But I spend a lot of the time in my clinic in the outpatient setting talking to my patients about how not to end up in the hospital and how to prevent their future risk of heart events, whether it be from blockages in the arteries or valve disease or electrical dysfunction of their heart. So I really enjoy talking about the prevention aspect of heart disease, which is mostly what I'm going to focus on today. So I think in order to understand your heart and understand how to prevent heart disease, you have to understand the components of the mechanics and electrical activity of the heart that go into how our heart functions. There's three major components to heart disease. On the top left of my screen, you can see the heart muscle, and those squiggly red lines that sit on top of it are the arteries of our heart. Those arteries give that muscle its blood supply and give that muscle its oxygen and its nutrients, and the muscle really depends on clean blood flow through those arteries in order to be able to pump. And when it pumps, then it pumps blood to the rest of our organs. And so one major component of heart disease is blockages or plaque buildup in those arteries, and that's what you're talking about when you talk about heart attacks. Another component is heart valve disease. So the heart muscle pumps blood, and that blood flows through our heart valves in order to be transported to the other organs of our body. And so heart valve disease is another component. and that generally is picked up on an echocardiogram or an ultrasound of a heart, or even, you know, primarily when your primary care physician listens with their stethoscope, they may hear a murmur and may tell you you have a murmur. That murmur is the turbulence of blood flow through our heart valves. And so if there's something that's picked up early on, then you're referred to a cardiologist to look for valve disease. Congenital heart disease, so those of us that are born with a heart defect, that would also translate into your primary care physician will sometimes hear a heart murmur, and you'll be sent for an ultrasound of the heart. The third component is really the electrical activity of our heart. So you hear about someone who has a pacemaker, or someone who has a heart rhythm disorder. That's really referring to the electrical activity, and the mechanics and the electrical activity, all of those components work together to allow this amazing muscle to pump blood to the rest of our organs and give blood supply to our brain and to our stomach and to our legs and our organs. And so it's really a vital component of your well-being. So like I said, the heart pumps blood to our organs, and it does so by pumping about 3 to 5 liters of the total, 3 out of the 5 liters of the total blood in our body is pumped every minute by the heart. And if you look on the left side of the screen, you'll see an image of the heart that's open, and you can see the purple blood or the dark blood, and that's the blood that's returned to our heart after all the oxygen and nutrients have been extracted. And then that blood is pumped to our lungs, and we take in our oxygen, or we take a breath in, and we oxygenate that blood and send it back to the left side of the heart. And then it's pumped to the rest of our body, and that fresh, good oxygenated blood is then travels through our body and is extracted from our organs. So that's kind of how the flow of the blood works through our body, and understanding that is really important when we talk about circulation issues in the legs and the arms. When the left side of the heart pumps that blood to our organs, it also pumps that blood into the arteries that sit on top of the heart. And those were the arteries that I showed you earlier in the previous slide. So why is heart disease important? It's a preventable disease, and it's very prevalent. It's a leading cause of death in the United States. One person dies every 36 seconds from some form of cardiovascular or some form of heart disease. Currently, about 655,000 people die each year in the United States from heart disease. That's 1 out of every 4 deaths. And it's a huge health cost. It's in 2014, $219 billion were spent on the management of heart disease. So it's such an important preventable disease and that's why we talk about it. And this data is from November of last year, during this COVID pandemic that we've been dealing with. You can still see that the leading cause of death at that time was still heart disease. Currently, about 48% of people in the United States have some form of heart disease, whether it's coronary artery disease, valve disease, or some form of electrical dysfunction of their heart. So it's close to half the people in the country. So, you know, we used to think that heart disease only killed men and only killed older men. And I think what we're discovering more and more now, and what research is showing us, is that heart disease does not have a typical picture of a typical person. It affects everyone at all ages. And I kind of wanted to put this picture up. When you go online, a lot of times you'll see mostly men, mostly older men that it affects, but really it affects multiple different races, ages, and especially it's becoming more and more prevalent in women. So you might see elderly women, you may see young women. So really there's no one person that you think of that you think, oh, that person is more likely to have heart disease. It affects all ages and races. It's more common in the African American population. Patients over the age of 65 are more likely to have some form of coronary artery disease or plaque buildup in their arteries. It does affect men at a younger age. However, it is the #1 killer in women as well. So I really don't think that you can judge a person when it comes to heart disease. It could be anyone or any one of you. So I'm going to focus a little bit on heart attacks and plaque buildup, because that's one of the main emergencies that we see when patients come into the hospital or come into the emergency room, and kind of describe what are the common symptoms or signs of a heart attack. So heart attacks, generally you'll read about, this left-sided pressure or an elephant sitting on my chest. A lot of people will think that that's the most common way to present. And although it is, there are other more subtle findings that could kind of alert you that maybe you need to either go to the emergency room or seek out medical help. Chest discomfort is how I would describe it, because some people will tell you that their chest felt like there was pressure across their chest. Some people will tell you it was a sharp pain. Sometimes you'll feel nauseous, or you'll have lower abdominal pain. We also sometimes see jaw pain, or kind of a heaviness or a pressure in the jaw, lightheadedness, shortness of breath. And about 1/3 of women who have a heart attack will, when they studied a population of women, had some unusual fatigue symptoms a couple of weeks before they presented with their event. So you can see that there's a whole different array of symptoms. What I will say is that heart disease generally will present as an exertional symptom. So if you're an active individual, most commonly you'll start to feel symptoms when you exert yourself. So let's just say you jog 2 to 3 miles a day, you'll start to notice that you feel chest discomfort or jaw pain, or some symptom when you're doing that level of activity. If you're extremely active and you have pain only when you're resting or only when you're falling asleep, then it's less likely to be related to a blockage or plaque buildup. And the reason is because when you exert yourself, you put stress on your heart. And when you put stress on your heart, that's when you start to show symptoms, if in fact that pain or discomfort you're having is related to a blockage. So how do you know if you're at risk? How do you know if you have risk factors for heart disease? Well, I kind of categorize risk factors for heart disease in 2 categories: modifiable and non-modifiable or unmodifiable risk factors. And there's some very standard modifiable risk factors that I'm sure most of you are aware of that I'll go through. And then there's some new research that's come out talking about other risk factors that we don't really think about or talk about. So smoking obviously is one of the most common and highest risk factors for heart disease, in addition to other disease processes like lung cancer. Your total and your LDL, or your quote unquote bad cholesterol, is a risk factor for heart disease. High blood pressure, which I'll get into in terms of treatment and when to be concerned about your blood pressure. Low HDL cholesterol, and that's your good cholesterol. Obesity is certainly a risk factor for heart disease. And physical inactivity, not being active is a risk factor. And a lot of times, I'll ask my patients, do you have chest pain? And they'll say no. And they're completely sedentary. How do they know that they don't have chest pain if they're not active and doing some form of exercise to stress their heart out to know if that they have chest pain or not? Diabetes is a big one. Diabetes is a major risk factor for heart disease and kind of sets you apart. When we see patients who are diabetic, we assume that they have some form of plaque buildup in their arteries. So diabetes we really regard as a coronary artery disease equivalent, and it's a major risk factor. So if you're diabetic, you need to be seeing a cardiologist. You need to be talking to your primary care doctor about your 10-year risk of having a cardiac event. And then you have the non-modifiable risk factors, which really come down to your family history. And when is family history important? Family history is important if you've had a first-degree relative, either a parent, male first-degree relative less than 55 years of age, or a female first-degree relative less than 65 years of age who's had a cardiac event. And usually I'm talking about has had a heart attack when they were younger, under that age limit. Race, like I said, our African American population has a higher risk of coronary disease, and age, over the age of 65, your risk for heart disease obviously increases, although that doesn't mean that if you're under the age of 65, you have no risk. So obesity is an important risk factor, and it's a huge problem in our country. And abdominal obesity, or a waist circumference greater than 35 inches, has been shown to increase your risk of having a coronary event in the future. In postmenopausal women, we tend to have abdominal obesity. As our estrogen levels go down, our cholesterol goes up, and we develop abdominal obesity, and that becomes an increased risk factor for heart disease. Physical inactivity. If you're not active, and by active I mean doing at least 150 minutes a week of moderate exercise, or 75 minutes of vigorous exercise a week. And this can be cumulative. You don't need to do, 30 minutes a day. You can split it up and do 10 minutes, 15 minutes. So it all is additive throughout the week, but you have to do at least 75 minutes of vigorous and 150 minutes of moderate. And I'll go into the details of what defines a moderate amount of exercise. I'll show that in a slide a little further up. So high blood pressure is a common issue that goes undetected, because high blood pressure truly doesn't always have symptoms. Unless your blood pressure is in the 180 range or above 160, a lot of times, sometimes patients will complain of headaches and they won't know why they have a headache, or vision changes. But a lot of times people have no idea that they have high blood pressure, and undetected and having high blood pressure for a long period of time can slowly put you at increased risk of having a stroke, a heart attack, heart failure, kidney dysfunction. So all of these issues, because they're all interconnected and related to our circulation. So high blood pressure really is a silent risk factor for heart disease. And most people whose blood pressure is in the 140s or 150s don't even know it. So seeing your primary care doctor and having your blood pressure checked regularly is important to kind of assess your risk and assess your future risk of having a heart event. So I kind of talked about on the left side of the screen the traditional risk factors for heart disease. We talked about cholesterol, high blood pressure, physical inactivity, obesity, smoking, and diabetes. But there's a lot of non-traditional risk factors that we don't really talk about. Part of that is because we haven't studied them, and part of it is because heart disease was always viewed as a disease that affected men only, and so we didn't really talk about other risk factors that affect women. But there's a lot of research out now that looks at inflammation as a driver of heart disease. And when you think about inflammation, you think about inflammatory disorders like autoimmune diseases like lupus or rheumatoid arthritis. And that degree of inflammation in our body has been shown to increase our future risk of having a cardiac event. So some of the non-traditional risk factors that you might want to think about when looking at your own risk are preterm delivery, preeclampsia, hypertension during pregnancy, gestational diabetes or diabetes during pregnancy, autoimmune diseases such as lupus or rheumatoid arthritis or Crohn's disease, or inflammatory processes that may increase your risk of inflammation in the arteries of your heart. Breast cancer treatment, and depression. And these are things that we don't usually think about when we think about our heart, but there's good research to show that these are also risk factors for future events or future cardiac disease. So just to briefly touch on radiation and chemotherapy, radiation, especially to the left breast, increases your risk of heart disease and increases your risk of calcification or buildup of calcification in and around the arteries of your heart. And that risk, depending on how much radiation you've received, and depending on where in your body you've received that radiation, continues for a long period of time after the radiation dose was given. Radiation is known to increase the risk of developing calcification in the heart valves, and also within the muscle itself. Chemotherapy is also dose dependent, and it's also dependent on the type of chemotherapy you receive. And so with chemotherapy, most of the time your oncologist will request an echocardiogram or an ultrasound of your heart periodically to look at your heart muscle function. But it's worthwhile discussing it with your oncologist, whether you've had radiation or chemotherapy, whether or not you need to have some form of surveillance imaging of your heart or stress testing, which the recommendation right now for anyone who's had radiation therapy, especially to their left breast, is to have stress test every 5 to 10 years. Depression. Depression's a big one because it affects people, it affects your future risk of having a cardiac event, but it also affects people if they've had a cardiac event. So if someone has a heart attack and they have an underlying depression, they're less likely to survive that event, and they're less likely to make it out of the hospital alive. So they're more likely to die. We know that rate of depression is on the rise, and treating it, talking to your primary care doctor about your depression and getting it treated, you never thought about that, but really affects your future risk of having a cardiac event and how you will recover as a result of having a cardiac event. What about hormones? So I'm going to touch briefly on hormone and hormone replacement. You know, the life cycle of estrogen and testosterone in our body is very different. Testosterone levels rise and then remain somewhat stagnant, whereas estrogen has, you know, an increase and then a very sharp decline in our adulthood. So, and these hormones really do affect our risk for heart disease, and whether to have hormone replacement therapy has been an ongoing discussion for years. What I'll say about testosterone, the summary, and you can talk to your primary care doctor or your cardiologist about it, but if your testosterone levels are normal, taking additional testosterone is not recommended for someone who has existing coronary artery disease, as it could increase your risk of having a future event. And elevated testosterone levels beyond what's considered a normal range can have a negative impact on your risk of heart disease. However, on the flip side, if your testosterone levels are low, then replacing testosterone to get within a normal range can actually be beneficial for the heart. So that's kind of, so if it's low, under what it's supposed to be, replacing it can be protective. If it's normal and you're taking excessive amounts of additional testosterone, then it can be detrimental or have an adverse outcome for your cardiac risk. Estrogen. So we all know estrogen is critical to our reproductive function, and it's produced in the ovaries in women. It comes from our fat, from our liver, from our breasts, and our adrenal glands. Estrogen is important because it helps regulate our liver's production of cholesterol. And, you know, when we have and produce estrogen, it decreases the buildup of plaque in the arteries. It also helps preserve our bone density. So as we get older and our estrogen levels decline, we're at risk of having, you know, osteoporosis or osteopenia. And so it's an important hormone. The big question has always been whether estrogen replacement is beneficial or not. And there was a huge study that was done, and the outcomes I'll go over. The good about estrogen replacement is that it relieves menopausal symptoms. It reduces your risk of osteoporosis or bone thinning and fractures. And it does improve your lipid panel. As our estrogen levels decline, our cholesterol goes up. But whether or not this translates to protection of our heart is a different story. There has been, you know, increased risk of breast cancer, uterine cancer with patients who take estrogen replacement. So the Women's Health Initiative looked at postmenopausal women between the ages of 50 and 79 with an intact uterus, and looked at hormone replacement, and the outcomes that they actually found were that there was an increased risk of heart disease, increased risk of stroke, increased risk of blood clots, and increased risk of breast cancer. And as a result of that, they concluded that hormone replacement therapy should not be used to prevent heart disease. So it should not be used solely for the purpose of preventing heart disease. However, it can be used to relieve symptoms. And then when they broke down the study and looked at the same patients, but only took the ones that had had previous hysterectomy and received estrogen only, they saw some benefit in reduction in heart disease. However, that benefit was mostly seen in the younger age group. So in the age group of 50 to 59, there was a significant reduction in coronary disease and risk of stroke in patients who had a hysterectomy and were in the estrogen only or estrogen replacement only. So the conclusion of the Women's Health Initiative was in younger postmenopausal women, post-hysterectomy, estrogen alone may have some benefit in prevention. However, it is still not recommended by the American Heart Association, American College of Cardiology as a prevention tool. It is only recommended for the relief of perimenopausal symptoms if started early and tapered after a few years. Estrogen administered transdermally is less likely to increase the risk of blood clots. And estrogen should not be given to reduce your risk of heart events. Of note, estrogen replacement and smoking, quadruples your risk of having a cardiac event. So those are two things that should not be done together. So in reality, hormone replacement is not the definitive point. So heart disease begins at a young age. So being premenopausal doesn't protect you from heart disease. And suddenly when you're postmenopausal, your heart disease risk increases. It's not like that at all. There's so many other factors that contribute to your development of plaque buildup and cholesterol buildup in the arteries that estrogen replacement and estrogen in and of itself is just one small factor. So now we're going to talk a little bit about what you can do in terms of prevention, and really the focus of what you can do is lowering your 10-year risk. So how can you prevent yourself from having a cardiac event over the next 10 years, given the information that you have about your health right now? We spend a lot of time making choices to protect ourselves and our families. I asked my son to wear a helmet when he's riding his bike, and we just don't do the same thing to help ourselves or protect ourselves from the number one cause of death, which is heart disease. And really think about that, because in your daily life, you do things to protect yourself without even thinking about it. But when it comes to your heart, are you really making the same decisions and the same choices? So the most important way to prevent heart disease or valve disease or rhythm disorders is to promote healthy lifestyle throughout your life. That's the number one thing that you can do. And how do you do that? You don't get frustrated with yourself. You make an appointment and you see your primary care doctor. And the first step in looking at your 10-year risk of having a heart event is to talk to your primary care doctor or your cardiologist and have a risk estimation. And risk estimation is done, there's three major programs that can give you your risk estimation. One is the PCE. The second one is the Framingham risk score, and the third one is the Reynolds risk score. And these risk calculators look at you as an individual and at your risk factors. So they take into consideration your age, your smoking status, your blood pressure, your cholesterol, your family history. And based on these factors, they tell you your risk of having a cardiac event over the next 10 years is low, intermediate, or high. And again, this is just a calculator, so it's not, definitive. And then when you take that low, intermediate, or high risk, Then you can think about what are some of the other risk factors that we talked about, the non-traditional stuff, the inflammatory processes, the autoimmune disorders. And, you know, you can your physician will help you bump up your risk or lower your risk depending on your individual criteria. But that's the first question that you should really be asking your primary care doctor or your cardiologist is, what is my 10-year risk of having a cardiac event? And if you're between the ages of 40 and 75, this is something that you need to address once a year. In patients who are between the age of 20 and 39, probably you need to have this risk assessment done a little further out, maybe every 3 to 5 years. And then after that, you focus on how you can reduce your risk or how you can reduce your 10-year risk. And one of the easiest things to talk about is diet. So the American Heart Association, American College of Cardiology will tell you that you should consume a healthy diet that includes vegetables, fruits, nuts, whole grains, lean vegetable or animal protein, and minimizes the intake of trans fat, red meat, and processed meats, refined carbohydrates, and sweetened beverages. But that's a lot to think about. And you know, maybe you're asking, well, what specifically should I eat or not eat to reduce my risk? So this is not what the American Heart Association is recommending your diet to look like. And this is a little bit closer to what your diet should look like. So let's go through some of the specifics. So there's 3 main diets that the American Heart Association, American College of Cardiology recommends. One is the DASH diet, the other is the Mediterranean diet, and the other is the healthy vegetarian diet. All of these diets have been very well studied. And what I can tell you is that the sodium content, the alcohol content, and the sugars in your diet are extremely important. There's been a lot of studies, and I know there's a lot of Netflix videos, a lot of fad diets out there, but what the data shows us is that animal protein versus plant-based protein increases your risk of cardiac events. So increased levels of animal protein in your diet, when they look at patients who have higher meats and poultry and fish versus plant-based protein, the patients who have animal protein have a higher risk of cardiac events. The American Heart Association has looked at the Mediterranean diet. Interestingly enough, the Mediterranean diet has a higher benefit in reducing your risk of stroke. Dairy products have not been well studied in large randomized controlled trials. So whether or not you should or shouldn't eat dairy, I don't have good data to support that. But I think there's a lot of good research coming out that shows that a plant-based diet is really the way to go to reduce your risk. Sodium is very important. Sodium increases your risk of high blood pressure. And really, this chart right here that I took from the American Heart Association guidelines says that according to the DASH diet, you reduce your sodium to 2,300 milligrams a day. I would say drive it down less than 2,000. In some patients, I tell them less than 1,500 milligrams. There's an excessive amount of sodium in the food that we eat, especially in frozen foods, canned foods, and restaurant foods, and fast foods. I mean, you accumulate sodium in your diet very quickly, and that's a huge driver of high blood pressure. Alcohol intake, the recommendation is one drink per day for women and 1 to 2 drinks for men. What about exercise? I talk to my patients a lot about exercise. It's one of the first questions I ask is, how do you stay active? And a lot of times the answer is, I just don't have time. I think that we all can make time, at least 15 to 30 minutes a day in our routine to get out there and move. And the American Heart Association recommends 150 minutes per week of moderate intensity and 75 minutes per week of vigorous intensity activity. And so what does that mean? It means once our gym's open, you get to the gym, but maybe take the stairs. But moderate level of activity refers to brisk walking, and biking, ballroom dancing, active yoga, or recreational swimming. And when you're walking about 2.4 to 4 miles per hour. And you can set that on a treadmill, or biking 5 to 10 miles per hour. Vigorous activity refers to jogging or running or biking more than 10 miles per hour. A singles tennis game will get you a vigorous level of activity in swimming laps. When I bring you into my office and you tell me you're having chest pain and I do a stress test, that's what I do. I put you through probably more like a vigorous level because I want you to get over 6 METs of exercise, and I look at your EKG. So if you're doing that on your own and you feel okay and you're not having chest pain, the chances are that you don't have a blockage in your artery. But if you're not doing moderate or vigorous level of activity throughout the week, there's no way that you'll know. You won't be able to tell me. You'll tell me you feel fine, but you're not exerting yourself enough to really know that. So I think all of us can find at least 30 minutes a day in our routine to get out there and go for a walk at an incline at a little bit of a vigorous pace to get our heart rate up, and to get our exercise in. Smoking, I'm not going to spend too much time talking about smoking. I think everyone knows the detrimental effects of smoking. The only thing that I want to mention about smoking is secondhand smoke is equally as detrimental for your heart health or heart death as is smoking firsthand. The other thing that I want to mention is these e-cigarettes or electronic nicotine delivery systems, as they call them, are still considered a risk factor for heart disease, and the studies that we've done on them have shown increased risk of heart rhythm disorders such as atrial fibrillation or some form of tachycardia or fast heart rhythm or abnormal heart rhythm, as well as increased risk of high blood pressure. Those who have quit smoking and have quit for more than 15 years, their risk of heart disease is the same as someone who's been a never smoker. So the longer you stay away from cigarettes, the better, and you can actually kind of reverse that risk if you've quit for more than 15 years. What about aspirin? Aspirin, we used to give all of our patients aspirin if we felt like they had a slightly higher risk, but there was a large study that came out in 2019 that really changed the way we use aspirin. And it is no longer really recommended for what we call primary prevention, meaning that if you've never had a cardiac event, never had coronary disease, then there's really no benefit in taking aspirin as a prevention. So if you're otherwise healthy, you don't have any other risk factors, and you come to my office and you say, should I take a baby aspirin? I'm going to tell you that there's really no benefit. And then there's been shown to be some level of harm in terms of increased risk of bleeding in those patients. In patients over the age of 70 who have no real cardiac risk and have never had a cardiac event, taking aspirin as a preventative medication is no longer recommended. If you're between the age of 40 and 70 and you're higher risk, what does that mean? That means if you're diabetic or if you have multiple risk factors, and if your primary care physician has gone through that risk tool and put you in the higher risk category, then there may be a benefit in taking a baby aspirin, but otherwise we don't really recommend it. And baby aspirin is by definition 81 milligrams, and enteric coated is what's recommended if you do take it, because it lines the stomach and reduces your risk of ulcers. What about cholesterol medications? So cholesterol medications, their first line, statins are the cholesterol medication that's first line for prevention, and are recommended in patients who have a bad cholesterol of over 190. Also, we recommend patients who are diabetic between the age of 40 and 75 to consider taking a statin. I'm sure some of you have heard of some of the newer agents, the PCSK9 inhibitors, the Praluent or the Repatha. You might see commercials. Those are really reserved for patients who are intolerant of statins for some sort of muscle breakdown, or for patients who cannot get to their goal LDL level, then we add Praluent or Repatha to help achieve that level. But statins are really the first line cholesterol medication for patients whose LDL is greater than 190. When you get your blood tests, you get your LDL level, and then next to it says reference range, and it always says that normal is less than 100. That normal is not what you should look at. Again, your goals are specific to you and specific to your other risk factors. So your LDL cholesterol level goal may not be less than 90. It may be less than 130 or 160, and that's something you need to discuss with your primary care physician based on all your other risk factors. Blood pressure. So it's amazing what lifestyle interventions can reduce your blood pressure, and I'm going to go through those. But generally speaking, we request that patients start treatment if their blood pressure is greater than 140/90, despite doing all the lifestyle interventions. And the goal is to get your blood pressure under 130/80. And here's some of the what we call non-pharmacologic interventions, and you'd be surprised to know that your diet, weight loss, and the amount of sodium that you take in can really affect your blood pressure. So if you look at the data, we can see that weight loss, eating a heart healthy or the DASH diet, or reducing your sodium intake, or eating a diet that's rich in potassium can bring your blood pressure down by anywhere from 5 to 10 points. And dietary sodium, I'll tell you, is huge. If you eat a meal the night before that's very high in sodium, you'll wake up the next morning and you'll probably notice your fingers are a little bit tight, and you'll check your blood pressure is going to be high. So sodium, tends to retain water and tends to drive up that blood pressure. So reducing your sodium intake, like I said, less than 2,000 milligrams, if you can, less than 1,500, you'll notice that your blood pressure will come down. And then dietary potassium. So you don't want to actually take potassium supplements, because potassium supplements can be detrimental to your heart if they're not discussed with your cardiologist or primary care doctor. But just foods that are rich in potassium, like bananas, can help reduce your blood pressure as well. Physical activity is huge. So if you participate in a regular amount of physical activity weekly, then you're going to notice that your blood pressure over time is going to come down. Physical activity in and of itself at the time that you're active is going to increase your blood pressure. So if you check your blood pressure, then you run, 3 miles hard and check your blood pressure, it's going to be elevated. That's a normal response to exercise. But over time, it actually has what we call a vasodilator or a dilatory effect on our arteries and relaxes our arteries and brings down our blood pressure. Again, you could bring down your blood pressure anywhere from 5 to 8 or 10 points just by being physically active. And then the most important type of physical activity is obviously aerobic exercise. You can do resistance training if you want, but we see the most benefits with aerobic exercise. And alcohol consumption is a big one, especially with beer. You'll notice if you stop drinking excessive amounts of alcohol, your blood pressure comes down over time as well. So here are the blood pressure numbers and goals. I'll leave this up for you. I think these slides are going to be available to you. But essentially, if your blood pressure is anywhere from 130 to 140 over 80 to 90, you're in that stage 1 high blood pressure range. And you really need to start doing some of those non-pharmacologic therapies that we discussed, such as reducing your sodium intake, exercising regularly, looking at your weight and participating in some weight loss program. However, if you fall into a high risk category, let's just say you're diabetic or you have a strong family history, then you may need to talk to your physician about starting you on a medication. And without doubt, anyone who's got a blood pressure over 140/90 has true stage 2 high blood pressure and needs to be on medication. So that's kind of almost sums up my talk. I want to just point out that, most of us look for the best of the best in everything that we do. When we have when you have your car breaks down, you want the best mechanic. When something goes wrong with your plumbing, you want the best plumber to come over to your house and fix it. But for your own body, a lot of times you'll follow just random advice from friends and people that don't really know the research behind it. And so I think a lot of what I've shared with you has been, research proven. I have data to support, what I recommend. And I think that's what you should follow and discuss with your primary care doctor, your 10-year risk of heart disease. And then I'm going to finish my talk with just one type of heart disease that I think a lot of people hear about and are curious about, and it's called broken heart syndrome. And I don't know if anyone's heard of it, but the heart is a very emotional organ and responds to emotional stress just as much as it does to physical stress. And there's a syndrome called broken heart syndrome that's more common in women, and it's when the heart becomes dysfunctional suddenly after an emotional stressor. So as an example, when I was in training, I had a lady come in whose dog had died, and she presented to the hospital with chest pain that was very much classic, like she was having a heart attack. And everything with broken heart syndrome presents like you're having a heart attack. Sudden, chest pressure, feels like an elephant sitting on your chest, feels like chest discomfort, and even your EKG in the emergency room may look like a heart attack. Yet it's not a heart attack. Your arteries are not clogged up. It's more that your heart has suddenly had a huge amount of emotional stress and the heart becomes dysfunctional. And I'm going to share with you what that looks like. Let me just pull this up 1 second. And what happens is when we inject dye into the heart, we see the heart balloon out, and you can see at the bottom right of my screen, this is the bottom portion of the heart. It just doesn't move. And this is called broken heart syndrome or Takotsubo cardiomyopathy. And it's when there's a sudden emotional stressor to the heart, and the heart function just stops working. It doesn't squeeze normally, and patients present to the emergency room as if they're having a heart attack. And when we go in and we take a look, their arteries are all clean, but the heart's not moving. The one thing about Takotsubo cardiomyopathy or broken heart syndrome is that patients will fully recover after 2 weeks or 2 to 3 weeks. Their heart muscle can recover and go back to completely normal. And the reason it's called Takotsubo is because the heart shape becomes the shape of what's known as an octopus catcher. And that's why it's also referred to as Takotsubo. So thank you so much for spending your time listening to my talk. I hope that it was helpful, and I'm ready to answer some questions if anyone has any. So I appreciate your time.
Thank you, Dr. Azadi, for that interesting presentation. Took me back to my anatomy course, and then lots of things to learn about heart disease. I'm sure that it was beneficial for many. So before we begin our Q&A, we have a few questions for you. If you could please take just a minute or two to answer the poll that you see appear on your screen and give us your honest feedback, we would greatly appreciate it. We can only get better. All right, so as you're answering the poll, Dr. Azadi, we have some questions here. So first question is, what are the statistics correlating gestational diabetes to heart disease? Should a person in their mid-30s get a heart screening if gestational diabetes occurred twice in both pregnancies?
So that's a great question. So yes, so Although I don't have the specific numbers in front of me, it is a well-known risk factor for future cardiac events. The statistics are mostly that gestational diabetes increases your risk of future fasting glucose issues or even diabetes in the future. So we know that people who have gestational diabetes may or may not in the future develop diabetes, and that then translates into development of coronary disease. So in terms of a heart screening, I think the important or relevant pieces of information would be to pick up your fasting glucose yearly with your primary care physician, as well as your cholesterol and your blood pressure. There's no association between gestational diabetes and heart valve disease or structural heart disease. It's more that it increases your risk of coronary events through having increased levels of fasting blood sugars, blood pressure, and cholesterol. So those are the components that I would look at through your primary care doctor or through a screening or whoever you can get those blood tests done with.
Great. The next question is an echocardiogram a good test as a baseline for cardiovascular disease?
Great question. So an echocardiogram looks at the structure and function of your heart. So an echocardiogram will pick up if you have any valve dysfunction, such as a leaky valve or a valve that's not opening well. It'll give you an idea of what your baseline heart muscle function is. It does not give you an assessment of, or any kind of indication of a blockage in your artery, for example. That's usually done through a stress test, okay? And that would be whether it be a stress echo or an exercise treadmill. Now, if you get an echocardiogram and the echocardiogram shows that you have heart dysfunction, so your heart's ejection fraction or pumping muscle looks weak at rest, then one possible reason for that could be that you've had coronary disease for a long time, and that has resulted in a weakening of your heart muscle. So to have a baseline can give you information. If the heart is weak, you'll need further testing, but it does not tell you that right here, right now, you don't have any blockages, because it's not a stress test.
Thank you, Dr. Azadi. So the next question is, if early menopausal, like age 48, taking HRT for relief of symptoms, can that lead to cardiovascular disease at age 58?
So the study that I showed really showed that if you have early menopausal and you're taking hormone replacement therapy early on, that through that Women's Health Initiative, that was actually somewhat protective in younger women who were taking estrogen only, who'd had a hysterectomy. However, taking it long term, and as you get older, there can be some increased risk. And what I would suggest is, if you're taking it for symptoms, then continue to take it. But then I would suggest seeing your primary care physician or a cardiologist to kind of look at your overall risk, and if you have other risk factors that would contribute to increasing your risk of heart disease.
Great. Your next question, is it recommended to get LDL down to about 40 if high risk?
So the recommendation for LDL in high-risk individuals, and let's just say, for example, you've had a heart attack or you have coronary plaquing that's significant in your arteries, the recommendation is to get your LDL under 70. So a range of 40 to 70 I would be okay with. It is not recommended that lower than that is better in any way. In the high risk category, if you don't have known coronary disease, so if you've never had a heart attack, never had a stent placed, then I would suggest maintaining your LDL under 100 would be beneficial.
Great, thank you. What about if the blood sugar is too low, like 90/60? I was told to take extra sodium to elevate my blood pressure. Am I doing okay?
Sure. So if you have low blood pressure, I think one thing to consider is whether or not you have symptoms. So some people's blood pressure is 90/60 and they feel fine, and there's nothing wrong with that. Blood pressure of 90/60 isn't going to kill you or harm you. If you have a blood pressure of 90/60 and you feel symptoms or you feel lightheaded or fatigued, then taking in additional sodium is fine. As long as your blood pressure does not exceed the threshold of 140/90. Some people need to take sodium or need to take sometimes even fludrocortisone or Florinef or something to hold water in to maintain a blood pressure. And that's fine to do.
Great, thank you. How do you recommend handling depression as a risk factor?
Sorry. That's a great question. So I think that, first of all, seeing a licensed physician for depression screening. So when we see patients in our office, and this is something I recently started doing, we do a formal depression screening, because sometimes unless you ask the specific questions, you're not going to really recognize or pick up on the fact that this person might be depressed. I think that the two ways that I would suggest, one would be counseling, which we have available, and we refer our patients to counseling all the time. And then in addition to that, pharmacologic therapy for depression is available and safe. If you have high risk factors for heart disease, or if you're in that high risk category and your primary care doctor wants to start you on a pharmacologic or a medication for depression, I would run that by your cardiologist and make sure there's no interaction. Some medications that are used for depression are stimulatory and they can elevate the heart rate. So certainly good idea to run those medications by your cardiologist or your primary care doctor. But I think counseling and medical therapy and exercise, it's been proven that regular exercise is a treatment option for depression. And so if you feel that you don't want to start medication or you're not there yet, starting a regular exercise routine is going to work for you.
Thank you. This would be our last question. And the other questions we will definitely respond to. You'll get an email. How valuable is a coronary MRI test?
That's an excellent question. I think there's two pieces to that. I think what you're referring to is a coronary CTA. We don't usually get an MRI to look at the coronary arteries. We get a CT scan. But I think that in young patients, so I would say anywhere age 40 to 60, a coronary CTA would be helpful because the arteries will be visible a lot better than in elderly patients who've developed some calcification. It's really hard to see if there's blockages in the arteries. So in young patients where you're concerned about heart disease, a coronary CTA may be of benefit. Sometimes patients are born with an anomaly where the arteries are squished between each other, and it's a congenital defect, and a coronary CTA would be beneficial. A lot of times it's hard to get coronary CTAs approved by insurance, but there are other ways that you can get them done. I know UCLA has an out-of-pocket program that's relatively cheap that we sometimes refer patients to. I think it depends on what your doctor is looking for. Ultimately, the gold standard for looking for blockages or plaque buildup in the arteries is an angiogram or a coronary angiogram. That is definitive, and it's also the modality we use to fix blocked arteries. So I think it's a discussion you need to have with a cardiologist before you request to have one done, because it really depends on what you're looking for, what your goals are in ordering that test. I'll just add one more thing. A lot of patients ask about coronary calcium scans. So coronary calcium scans are very useful pieces of information, and they look at the degree of calcification around the artery wall, not inside the artery. So they don't look for blockages. But it's very well known that patients who have a calcium score or a calcification scan that's over 100, their 10-year risk of heart disease is increased. So in a lot of my patients where I'm kind of borderline debating on whether I want to start them on a cholesterol medication or not, I get a calcium scan to kind of drive my decision, because I know that coronary calcification increases your risk of heart disease, and then I'll be more aggressive about treating their cholesterol. Whereas if your coronary calcium score is 0, then I won't be as concerned.
Thank you, Dr. Azadi. We have so many questions, so hopefully we can get back to them. But thank you to all of you for taking the time to listen and ask questions. A big thanks to Dr. Azadi for taking the time to provide us with valuable information. We will be sending a recording of the presentation to all attendees next week for you to have. We also will be posting this on our Facebook page for everyone to be able to view and share. You can find us at Little Company of Mary South Bay on Facebook. For any additional information or how to schedule an appointment or heart screening, please call our Patient Engagement Center at 1-888-HEALING, HEALING. Thank you again, and have a great rest of your evening, everyone.